Thank you all for joining me today. I'm Brian Miller. I'm a non-resident fellow here at the American Enterprise Institute. I think we're going to have a fun end of the day, and I realize that we're the barrier between y'all and cocktail hour. So we're going to try and have fun and then get you guys out the door with some new thoughts. We're about 4 months away from the election, 8 months from a new start in a new session in Congress that's going to probably affect everything from Medicare, Medicaid, FDA, regulation of artificial intelligence, public health agency reform. I just also wanted to be clear that today that each of our panelists, who I'll introduce in a moment, are here to represent themselves and not any of their institutions or affiliations. They're not speaking for any political party or any political candidate. And they're not going to be outlining policies that Biden administration or Trump administration is going to be taking. They'll be sharing their own personal thoughts. We're going to focus today on what happened and accomplishments from the prior Trump administration, the current Biden administration, in addition to what we expect Congress will be doing next year, especially with reconciliation on deck, potentially affecting many areas in healthcare policy. Looking forwards, Congress has traditionally been the funnel through which health policy ideas have been executed and filtered. And so that congressional oversight, legislation, and action is going to be a lot of our focus. We'll also have time for questions at the end. So we'll try and get to all of your questions. If we don't, please email Jack Rowing and we'll try to get them answered. So we have an excellent panel here today. At the end, we have my friend Ryan Long, a fellow UNC alum, Tar Heel. He is emeritus from long service in the House of Representatives, including Energy and Commerce Committee, where he served as FDA counsel, and also as a senior advisor in a variety of areas, most notably health policy for former Speaker Kevin McCarthy. We also have Brian Blais, who's the president and founder of the Paragon Health Institute, a exceptionally well-regarded and energetic new health policy think tank. He previously served as Trump's special assistant for economic policy at the National Economic Council and has also worked on the Hill. And then next to me, we have my colleague, Nina Schaefer, the director of the Heritage Foundation's Center for Health and Welfare Policy. She has previously worked in a variety of roles at HHS and also on the Hill. So I wanted to start off with you, Brian. You had this great study that came out. You showed sort of shocking findings in the ACA marketplace. I read it and sort of fell out of my chair because it was not exactly what I expected. What do you think Congress is going to do next session when the ACA subsidies expire?
Are these chairs sturdy, Brian? I don't want anybody to get injured here during my presentation. Thank you for the invitation to be here. It's great to be on a panel with you and Ryan and my first boss in health policy, Nina. So I have 3 slides to explain what I think is the biggest health policy issue right now, sort of outside of how the election could affect health policy. It's a topic that at Paragon we really started diving into about 2 months ago. I was in the state of Texas testifying before the state Senate. I was asked a question about how the Obamacare, the ACA exchanges were going. The Texas senator said, he had heard there was a lot of income manipulation, people underestimating income in order to qualify for more subsidies than they were entitled to. And I explained that that was occurring in Texas. I also talked about as a state that has not adopted the Obamacare Medicaid expansion, there was an incentive to overestimate income. And then I got back and asked the team at Paragon to dive into this issue, so if we could quantify exactly what was going on. And what we found was pretty significant. So before I get to this slide, 2 pieces of information, and this is very relevant to your question in what Congress should do next year on the ACA. One is how these subsidies work. So Obamacare, a whole bunch of mandates, makes health insurance more expensive, creates subsidies in order for people to afford them. The subsidies are based on what people estimate their income to be. So in the fall of 2023, people estimate their income for 2024. They qualify for a subsidy. That subsidy is then sent to the insurance company that offers the plan that that individual selects. At the end of the year, or really next spring, so during the tax filing season, there will be a reconciliation where the individual gets they're qualified for a tax credit based on their actual income, and if they got too much, they'd have to repay, or if they got too little, they would get an extra bonus. Now, there's limits on the amount that can be recaptured if the individual gets too much subsidy. So it's very complicated to figure out how to do this sort of estimating advanced tax credit to avoid waste and abuse. President Biden signed legislation that expanded the subsidies, so made the coverage free for people that report income between 100 and 150% of the poverty line, which leads me to this slide. We originally published this slide a couple months ago, and it had an error on it. And I hate to have errors on slides that we put out, but the error was in the title of the slide. We had over half of federal exchange enrollees have income between 100 and 150% of the poverty line. Our research indicates that they don't have income. They're just stating during the application process that that's their income. So you can see from this chart, starting in 2022, a surge of Obamacare enrollees reporting income that makes the coverage free for them. To the extent that this is healthcare.gov states, so 2/3 of states rely on the federal exchange, healthcare.gov. They operate the health insurance marketplace. More than half of enrollees this year claimed that their income was between 100 and 150% of the poverty line. For people that misestimate their income, this is the cost to taxpayers. So significant costs for lower income enrollees that estimate too little income. But enrollees above 200% of the poverty line, they also have an incentive because they're going to get more tax credit than they actually have to pay back. And here's sort of the key data analysis from the paper. We looked at the signups by FPL grouping for this population that gets free coverage and compared it to the actual number of people that are eligible for that coverage and found that in 9 states, there are more people enrolled claiming income in this category than are eligible. In some states, it is magnitudes more claiming this income than are eligible. In the state of Florida, there's 4 times as many people enrolled in the ACA reporting income that gives them free coverage than are eligible. Overall, we estimate there's 4 to 5 million people fraudulently enrolled in Obamacare plans, and that the cost to taxpayers is likely north of $20 billion just this year. Now, is this just enrollees that learn how to manipulate the program rules and are doing this en masse? No, right? This is a very sophisticated operation that's occurring that's been enabled by the Biden administration focus on enrollment in the exchanges above all else and a political imperative to get more people enrolled in the exchange to the extent that they're not verifying eligibility and they're not requiring that brokers that submit information on behalf of people actually know that have individuals that want to be enrolled. So there's been reports of lots of unauthorized broker enrollment into exchange plans and also brokers switching people from exchange plans to the other. This is devastating for people who have chosen a plan because they have doctors and that are covered, they have medications that are covered by the plan, then they get switched into a plan that doesn't cover their doctors or their patients. So there's enrollees that are harmed, taxpayers are clearly harmed. It's a huge windfall for these unscrupulous brokers that are advertising these free plans and for insurance companies. So again, if you hear the Biden administration touting expanded enrollment in Obamacare, which they are, almost all of the additional enrollment that we've seen over the last year or two is based on people fraudulently reporting income and brokers taking advantage of the fact that these enrollees don't have to pay anything, and that it's very easy to sign people up if they don't have to pay anything, and all they need from the enrollee is their name and birth date.
So I guess the fun thing about payment policy is it's sort of like Jeopardy. What's going to happen to the taxpayers and the enrollees in the states? Like, who is subsidizing what? What arbitrage is happening? What loopholes are being exploited? Which brings me, of course, to the example of California, Nina, we've talked about this at length. California has continued to sort of game the Medicaid funding system. They have a variety of, they have provider taxes, they have a Medicaid MCO, the managed care plan tax. How do these taxes work, and what do you think could happen in the next session to address these problems?
Sure. Well, again, thank you for having us. I think it's great to have a good conversation on healthcare. Might not rank high on people's polling list, but it affects every American. So healthcare, I think, continues to be an important issue. Before we dive into the details on the California gaming situation, I think it's important to kind of give a little bit of an education on how Medicaid works, because it is a unique program compared to other federal programs. It's actually a federal-state partnership where the federal government picks up part of the cost of what the services that the state delivers, and the state picks up the other part of the cost. And so that creates an interesting dynamic of the states wanting to leverage those federal dollars down to their states. There's a minimum of how much states can get. 50% is where California is. It can go as high as 70-something% for lower income states. So what's happening in California, I think, is an example of what happens in a lot of states that are trying to use this relationship in a way and kind of game the relationship to advantage the state. So in the case of California, the provider tax, for example, a state will tax an entity within the Medicaid system, whether it's an MCO, a managed care plan, or a hospital, or some other entity. They will tax them, use the revenue that they get from the tax that comes in from that entity to offset their share of the state dollars that they owe the federal government. Then, once they collect all the dollars, they take back that money that they taxed the entity and give it back to that, sometimes at a higher rate than even the tax was. So there's a lot of gaming going on. So that's one issue. The other part of that equation is also a waiver system. And by the way, California is not the only one who uses provider taxes. They're everywhere. So this is not just a California hit. This is across the states. The other situation that's happened here is that they got this through a waiver system. So the federal government sets rules through statute on how Medicaid programs need to operate. The states are the ones who actually administer the program. There is a provision that allows a state to come to Washington and ask HHS, we would like to test out something different outside of the parameters per se, and we need your approval. Well, one of the conditions of getting approval is that the state has to show that it would be budget neutral, meaning it's not going to cost the federal taxpayers any more than they would otherwise. So the system here, too, is that they've done this game here and using a waiver system that has some suspect of how the budget neutrality estimates have been produced. And so it really raises two issues within Medicaid that I think a new Congress or administration should look into, which is one, on the provider tax, there's great bipartisan support in the past for kind of ratcheting down on the use of provider taxes as one of these kind of gimmicks. And the other is on the budget neutrality piece on Section 1115 Medicaid waivers. GAO has done reports after reports about understanding what's going on with the budget neutrality question. And I think those two areas could provide a real kind of fertile ground for bipartisanship for members who actually want to make sure that the program, the Medicaid program, is actually being run properly according to what the statute has, and holding states accountable to making sure they're administering the program like they should be.
So continuing on the payment policy arbitrage for $300, I'm curious, I saw this hearing a few weeks ago, maybe it was a month or so ago, about the 340B program, which, to be honest, is not something I have kept enormously close tabs on. It seems like it had very much the energy of oversight in preparation for future activity. Ryan, you were in the House, you worked in Energy and Commerce, you also worked in leadership. What do you think could happen next session on 340B?
So, the 340B program, it's one that kind of flies under the radar, and it was a $2 billion program, I think, back in 2020. It's now over $55 billion. It's the second largest federal drug program. When we created it back in the 1990s, the thought was there are hospitals that have patients that have low-income, uninsured patients that need access to affordable medicine. So we will have drug manufacturers provide hospitals discounted drugs so those low-income patients could get affordable medicines. And that's really the way the program ran for about 20 years. And then around 2010, it really started to change because it started to be known as a hospital subsidy program. The reason I say that is because hospitals will buy the drugs at a discount, and then they'll get reimbursed by commercial insurance or Medicare at sort of that regular rate, and then they take the difference. And that's why you've seen this explosion over the last 12 years. More and more hospitals are getting into the program, but from a system-wide perspective, when a hospital goes out and buys a physician practice, now that physician practice that was buying drugs at the normal price are now buying that at the discounted price. The hospital gets to keep the difference between the acquisition cost and the normal reimbursement. So that's driving consolidation, which is increasing overall healthcare system costs. Now the problem is one, patients aren't guaranteed access to the 340B price. So the reason that we created the program to begin with, we don't know if that's actually happening. And two, because it's such an opaque and non-transparent system, we've developed this structure where if it is a subsidy for hospitals, most of the subsidy is going to hospitals that have the least need, and those that have the most need get the least from the program. And what do I mean by that? So if you're a hospital and you have 50% Medicaid, you have 30% uninsured, and you have 20% commercial insured, and the rest Medicaid, you're most likely not in a good financial situation. Medicaid doesn't pay well, you have a lot of uncompensated care because they're uninsured. Now, if you're a hospital that has, let's say, 15% Medicaid, so you qualify for the program, and you have the rest that's basically the commercial insurance and Medicare, you're gonna make a lot more from the program, but you probably need it a lot less. And so I think there are a lot of questions being asked. One, are patients actually getting the benefit of the program? Two, don't we need some transparency on how the money is flowing? Mm-hmm. And three, is the money actually flowing to those entities that need it the most? Now, what could happen next Congress? Back in 2010, the Obama administration, not through regulation, but through a sub-regulatory letter, said that hospitals could have as many contract pharmacies as they wanted. Prior to that, basically, if you're a hospital, you didn't have an in-house pharmacy in your hospital, you'd contract out with one neighborhood pharmacy. And your patients go to that pharmacy, they could get their 340B drugs. Well, when they lifted that and they said you can have as many as you want, now we have some entities that have 300-400 contract pharmacies. So the program's exploded, that's one of the reasons. And so the manufacturers said, we're not required under the statute to provide discounts to contract pharmacies. And some of them have just stopped entirely. Others have put restrictions, i.e. they want reporting and transparency for contract pharmacies that get the 340B discount. The hospitals have sued the manufacturers saying, you're required under the 340B program to provide these discounts to contract pharmacies. And so that's winding its way through the courts. We've had 2 circuit courts, I think the 3rd Circuit and DC Circuit, have said, yes, contract pharmacies aren't in the statute. Manufacturers aren't required to provide these discounts. I think there's one other circuit that it's sort of winding its way through. So when we get legal certainty, whether that's a circuit court split or circuit court unanimity, the expectation is there could be sort of this momentum to actually look at the program on the Hill. Up until this point, there's been a lot of investigations, there have been letters, but really sort of the momentum to get something done hasn't been there. And when we get finality in the litigation, I think you'll see people actually trying to address some of these issues, whether they do that in a fundamental reform way or just individual sort of silos, we'll see.
So that gets me to reconciliation in healthcare. All of these sound, pretty deep problems that require statutory intervention to address them. Brian, if Republicans have a healthcare reconciliation bill next session, what do you think will be done to bend the cost curve?
I'm hoping it's more successful than the reconciliation bill that we did on healthcare in 2017, first of all. So first, what is reconciliation? Just in case you're not familiar, it's a tool that allows Congress to pass legislation that is primarily budgetary in nature with just a majority in both the House and the Senate. That's obviously very important in the Senate because most legislation, you need 60 votes. To pass legislation out of the Senate. With reconciliation, you can do it with 50 votes. I will tell you, so there's a lot of, if it is Republican control next year, which, I think it's a reasonable chance that there is going to be unified Republican control, reconciliation is almost certainly going to be used to extend some aspects of the Tax Cuts and Jobs Act expiring provisions. A lot of the individual side provisions expire after 2025. What we are doing at Paragon is thinking through what proposals could fit in to reconciliation. Again, they would have to be budgetary. That would have there would be significant reforms to our government health programs. And from our perspective, we need to deal with the large and growing federal budget deficit that is, probably the primary challenge for policymakers and the primary threat to future American prosperity. So just a few thoughts. One, under no circumstances should Republicans extend the enhanced Obamacare tax credits. I think they are bad policy, they are inflationary, they are wasteful, they are mostly crowd out, and there's enormous waste and fraud associated with them. So that should not be considered in reconciliation. As far as positive reforms, some of this Medicaid financing, and in particular, I like Nina's ideas phasing out provider taxes. There's a lot of challenges, political challenges with phasing out provider taxes. The number one Medicaid financing reform that we're focused on is ending Obamacare's 90% match rate for the expansion population. So Obamacare, there's two Medicaid programs. There's one for the traditional enrollees, pregnant women, children, people with disabilities, seniors. States get a much lower federal reimbursement for those individuals. There's then a much higher federal rate for the able-bodied working age population brought onto the program by Obamacare. It is federal discrimination against the most vulnerable, and Congress should end that discrimination, and they should equalize the federal payment rates across populations. That would be significant entitlement reform. On Medicare, we think there's an opportunity for site-neutral payments in Medicare. It's, again, talking about 340B is a subsidy for hospitals. The way that Medicare payments are designed is a subsidy for hospitals because the Medicare program pays much more for the same service delivered in a hospital outpatient department than in a physician's office. It creates incentives for harmful consolidation in the market. So the proposal would be to equalize those payments at what Medicare currently pays for services in the physician office. And then I think there's some opportunities. Paragon will pitch the Medicare Advantage reform proposal that Paragon put out a few months ago. We think there's ways to strengthen MA to deal with some of the attacks on MA in a sensible way that would make the program more efficient and that would bring some significant budget savings as well.
It's quite the policy shopping list. Ryan, you have thoughts?
Well, I just wanted to add one more on the Medicaid side. Last year during the debate on the debt ceiling, limit, save, grow, Republicans included a proposal that would say for that expansion population, again, they're able-bodied adults, that there would be work requirements associated with Medicaid coverage that I think would come up in a reconciliation package.
So Ryan, I did want to put my public health hat on, being a public health physician. A while back, I had a panel on tobacco regulation. I had a bunch of public health folks up. Also had Dr. Larry Bouchon, a retired cardiothoracic surgeon on the Energy and Commerce Committee, talk with us. So tobacco-related disease still causes almost 500,000 deaths a year, which is a lot, in 2024. What do you think that the FDA has gotten right and wrong on tobacco regulation over the past 5-10 years. How can we better protect kids and also offer adults harm reduction options? And what can Congress do to sort of right the ship at the FDA?
So I went back and looked at the committee report when we passed the Tobacco Control Act back in 2009, and the dissenting views that we had on there. There was a lot of criticism that the structure that was put in place wouldn't actually allow for harm reduction, and that we were putting ourselves in this situation of all or nothing. And then you look at countries like the United Kingdom and countries like Sweden that have recognized the burden of cigarette-associated disease and the health burden, both from a personal standpoint, but also from a system-wide standpoint. And they've made the decision that we can improve people's lives, we can reduce healthcare expenditures by trying to transition people away from combustible cigarettes to non-combustible products, which I think is universally accepted as much healthier for you. I'm not going to say it's healthy. However, what I don't understand from our FDA over the past 5 or 10 years is what is exactly our philosophy when it comes to harm reduction. We have the standard for approving new products as appropriate for the protection of public health. And one of the problems we had when we were marking it up, it was a very amorphous sort of eye of the beholder definition that could sort of change from product to product. And if you're developing harm reduction products, you need some certainty from your regulator on what you need to provide them to actually get approved. And I don't think that we have that. And I think we need more clarity from the FDA on what that standard is. And I think we need a decision from sort of everyone within the public health community, including the FDA and Congress. Is our goal to try to move people away from combustible cigarettes? And if we do that, like the UK has decided to do and Sweden's tried to do, we can significantly reduce the burden of tobacco-related disease. And we can significantly reduce the number of deaths related to tobacco-related disease. But we have to have an FDA that has a clear vision that that's what they want to do. And whether that's through congressional oversight or potentially a new commissioner, they need to have more of a focus. They need to provide more predictability and stability or consistency on how they're going to go about reviewing applications and make the determination that, yes, we want to provide an environment where people that smoke are going to transition away. The idea that we are going to take away all options for smokers and maybe all you have are the over-the-counter gum, we know that doesn't work. And so we need to be a little more practical and realistic about what does work in the real world, rather than this sort of false choice of all or nothing.
Where does cannabis fit in?
Well, that's really interesting because, when they passed the Tobacco Control Act, there were a lot of people that were suspect of the FDA and their ability to regulate these products properly, given the FDA's historic sort of focus on regulating, the safety and efficacy of devices. These are not, by definition, safe products. I think there is a bill in the Senate that it's the legalization bill. I forget who the sponsor is, but it's kind of ironic, the fact that for tobacco, they would say you need to get every product pre-approved. We're not necessarily going to provide you what the standard is for doing that. But for cannabis products, even combustible cannabis products, you're not even going to have an approval for FDA. You just get to sell it, and maybe we'll, monitor the market. So there is kind of a schizophrenic policy position when it comes to those two.
Yeah, that doesn't make a lot of sense. It's not consistent. I didn't want to talk about, because we talked about the ACA expansion population with the increase in Medicaid enrollment. I know that we also had an expansion of the Medicaid population during the pandemic, and then we've had this slow disenrollment. States have taken a variety of approaches, and then at times the federal government has or has not stepped in. What do you think is going to happen during the next session, Nina, with Medicaid and with the wind down from the pandemic?
Well, just to kind of bring everyone up to speed on what happened during the pandemic. So when COVID hit, the federal government, Congress passed legislation that would give states additional federal dollars to maintain their Medicaid programs, with the one catch that they would not change eligibility determinations within the program. So kind of like freeze the population that's on your program and you keep getting the money. This, unlike the subsidies for the ACA, Congress had the wisdom to say, wow, COVID's over, it's time to start winding this down. And so they did begin to kind of take down that federal match rate and allowed states then to start getting back to business as usual, figuring out who's eligible, who's no longer eligible, and start kind of resetting their Medicaid rolls. I have found it kind of surprising that it seems that this administration, not only with the subsidies, being lax with enforcement on that, but the same with the Medicaid enrollment. It seems to be that this administration is looking to make Medicaid as the default coverage option for anyone who doesn't have health care coverage. That is not what the intent of the program is. It also seems to be measuring success as the number of people on the program. The higher the number, the more successful the program, which seems odd to me because a program that's a safety net program that's intended to be for only those who have hit hard times, need a safety net, need some additional assistance. The goal should be actually, let's see how we can make those numbers smaller, because that means those people no longer need government assistance and are moving back into the economy, getting jobs, upper income, et cetera, or raising their incomes, et cetera. So I find that the idea that that the administration has of, well, we just want everyone to stay on Medicaid is really going to be problematic moving forward. We see efforts already, them chipping away at having continuous coverage for children in CHIP and Medicaid. So even if you become ineligible during the season, it doesn't matter, you can stay on for the full year. I suspect we'll see more of that moving forward, new groups of people that they'll want to keep on continuously throughout the system, and really make it the one-stop shop, which is if you don't have health insurance, don't worry, you can stay on Medicaid and we'll keep you there. I think what we really need to see is kind of a reset where we make sure that the program is very similar to what Brian said earlier, which is a program for those who truly need it, and make sure that the resources that are there, limited at the federal and state level, are actually helping to provide the best quality care for the people who need it the most. If you add too many people into a system, everything gets thinner. You're going to have fewer benefits, fewer providers, less generous services. We should be looking to find a way to right-size the Medicaid program, make sure it's really there for the people who need it, and of course, finding ways to help them find a pathway out. And I think Ryan's point about the work requirements, we have it in welfare. I don't know why we can't have it in Medicaid as well. Able-bodied people should be encouraged to find work. That should be a positive thing that we should be encouraging people, because if they work, they have an income and they don't need the government assistance and they can be self-sustainable. So
I have another question actually about Medicaid. So a lot of my policy colleagues often talk about red states versus blue states, Democratic experts versus Republican experts, and I don't actually think that's necessarily the case in Medicaid. It actually seems more like it's the federal government fighting with states, sort of regardless of parties, because it's an expense for Congress, and the states have incentives to transfer costs and federalize costs. So what do you think could happen during the next session for leaders in Congress and the various committees of jurisdiction to balance sort of that desire for lower Medicaid spending, but also with the wishes of the governors in their home states? How do you, because that's a really hard tension.
yeah, and I think that's why we haven't been successful at more comprehensive Medicaid reform. I mean, we've had Medicaid commissions that have tried to kind of bring the two sides together. What we end up having is a little bit of this little piece here, this little piece here. It doesn't make the kind of reforms that we really need. I think it's a real challenge. I mean, I think what would be wise if policymakers want to kind of get a jump start on this is to try to pull together some of those governors across a wide variety of states who have different interests and different demands, some of the higher income states with lower income states, states with high populations of enrollment, states with low, and begin to really pull together a group to start thinking about what is the right balance here. How can we reset the Medicaid program in a way that's sustainable both for the federal taxpayer and the state taxpayer? I think one thing, Brian's point on rebalancing the financing, that's going to require states' involvement, and so getting them in early to start talking about that, and then having something to offset that trade-off for them. If they're going to have to take, quote unquote, a haircut in some places, what do you trade off for that? Something perhaps like greater benefit flexibility, so they don't constantly have to go to Washington and ask for a waiver, giving them some statutory certainty on some things so that they see that, well, if we have to take some financing cuts, we'll at least have some greater flexibility of how we want to design and administer the program within the system. But I totally agree with you. I think unlike a lot of debates in Washington where it always seems like someone says this is a blue state versus red state issue, this is really a federal versus state issue. There is no color divide at the state level. And I think that's a real challenge because if you work on Capitol Hill, you know the first person that calls you when something happens, it's your state representatives, it's your governor's office, it's the state senate calling you to say, this is going to hurt our state budget. And as federal elected officials, the temptation is always to say, well, I better do what's right for my state. But at the same time, there's the trade-off of federal officials are elected to also represent the nation as a whole and federal taxpayers as a whole. It's a hard balance, but I think it will take some courageous policy leaders both at the federal level and courageous governors at the state level who are willing to kind of sit down and hopefully come up with something that's sustainable for all.
I appreciate that, Brian. I'd welcome your thoughts on that. And then also consolidation. We've seen consolidation throughout the delivery system, throughout healthcare. What do you think has resulted in that? And what do you think we can do to increase competition in healthcare? And what should Congress be doing and thinking about during the next session?
All right, so let me do the latter question first and then come back to Medicaid. One resource here, President Trump in the fall of 2017 signed an executive order on promoting choice and competition throughout the United States healthcare system. And we released a report that following December, which is over a 100-page report on what can be done on both the demand side and the supply side. On the demand side, we want people to be more in charge of spending their own money on the healthcare that works best for them. A lot of the innovation is going to occur when people have incentives to be cost-conscious consumers, and they have insurance products that just aren't prepayment for medical care, but are designed in such a way that the consumer has an incentive to care about what the prices are across the different providers. And that requires flexibility in the ways people can finance their health care, which was limited by the ACA. But there's an opportunity on the employer side for employers to drive some of this innovation. On the supply side, we need to get rid of all the government payment policies that incentivize consolidation. So anything from site-neutral payments to 340B that provides incentives for consolidation, we should get rid of the problems that are largely in how Medicare, because what Medicare does, as you know, Brian, very well, is that its payment policies have extra power because the commercial payers often bench what they're doing to what Medicare is doing. On the supply side, too, a lot of this is state issues. So states regulate what providers can do. They should allow all sorts of healthcare professionals, doctors, nurse practitioners, physician extenders to practice at the top of their ability. We should get rid of the most anti-competitive policy that I've ever heard of, the certificate of need laws that require to build supply, you have to get approval from a government entity that is often dominated by the competitors, the entrants in the market that the new entrant would be like competing against.
One hospital asking another hospital if it's okay if they build a third
Yes.
hospital next door.
Yeah.
Pretty ridiculous.
Yeah.
So sort of turning our prior thoughts on the head, we talked about what a Republican reconciliation bill could look like. What do you think would happen if Democrats swept Congress and had a reconciliation bill? Because we saw a $900 billion spending package and an attempt at a $3.5 trillion spending package. What do you think would happen this go around?
I'll chime in. So I think on the Medicaid front, we'll see more of the same. We'll see continued expansions. And I think what we need to watch for more is with the combination of what they're trying to do with Medicaid enrollment, keeping more people on the Medicaid rolls, with the additional subsidies, which we will likely see, President Biden has already said he wants those ACA subsidies permanent, not temporary. The combination of the two is kind of a danger zone, I think, and that people need to have on their radar. You could see some states coming to Washington looking for waivers both within the ACA and the Medicaid to create, in essence, either a public option or a single-payer system within their states. And I think this administration would be much more, in a second term, much more open and creative of making that work for them. We already have a few states who have tried public options, not as perhaps as successful as they had wanted to, but if they could find ways of leveraging additional federal dollars to make it work, I think they would. So we would need to keep an eye on that for sure.
Thank you. And Ryan, going back to public health, during the pandemic, we saw institutional trust and just the decline of trust across public health institutions for a wide variety of reasons. As a public health physician and an internist, obviously this is of concern to me. It's of concern to many of my colleagues. But in some sense, there were rational reasons behind why there was a decline in trust in public health institutions. What do you think Congress can do to help public health agencies re-earn the trust of the average citizen?
Yeah, at the end of the day, you look at some of the things that we were told, and we were told this is science or is based off of science. And we knew then, and we know even more emphatically now, that there wasn't really any science behind that. But yet that data was used to justify particular policies that were very unpopular. I mean, you look at the Department of Education threatened to sue 5 states and take away their education dollars if they didn't have mask mandates in schools. There was no data to prove that. And I think that they trotted out a study from Phoenix, Arizona, and said, well, this is the seminal study, and that was basically shredded within a day. But that didn't stop the Department of Education saying we're going to sue I think Arizona, Florida, Tennessee. I mean that's one example. There are a whole host of other examples that we saw through the pandemic that we were told emphatically, yes, this is true. And then you looked underneath the hood, there wasn't really any data to support it. And so I think people became very suspicious of public health entities. There are things that Congress can do. I think the Energy and Commerce Committee and Senate Help Committee, they've done requests for information on how we can improve the functioning governance of the CDC and the NIH. And that's really well and good. But at the end of the day, until those people admit how they deceive the American people and show some accountability, it's going to be hard to regain that trust. And from my perspective, I think it's critically important that people have trust in our public health institutions. We don't know what's going to come next year or in 5 years. We've seen a reduction in childhood vaccines. I think it's critically important that children get the MMR vaccine. I mean, that's something that we can get rid of, measles in this country. But there's skepticism because they don't trust our public health officials. And that skepticism won't go away until they actually show some accountability.
So do you think you see a primary role, it sounds like, for oversight?
Well, I mean, it is oversight, but let's take another example. There's a discussion now going on about surgeries for minors, and we were told by Secretary Becerra at a hearing back in June at Energy and Commerce that the data is overwhelming. Everyone agrees, except for the fact that there was a seminal report that came out of the UK that said everything that they've been relying on isn't actual scientific data. And then it comes out that the Assistant Secretary of Health went and urged this advocacy organization that they base their recommendations on to change them, and to change them related to surgeries. Now, the White House, I guess 2 weeks ago, came out and said, hey, we're against surgeries for minors, yet they're still undergoing litigation against the state of Tennessee that has that prohibition. They still have a guidance on their website that says, if you've been affected by this, tell us and we'll sue a provider. And so this need for accountability, it doesn't seem like it's actually seeped through to those people that need to be accountable.
so accountability and public transparency. I also know that the next session is going to potentially tee up user fee negotiations for a variety of areas under FDA product regulation. I also know with the recent Chevron case, there have been concerns that the agency and other agencies won't be able to undertake sort of routine regulatory practice. I personally disagree with that, but I'd be curious for your thoughts about how Chevron could or could not affect FDA product decisions. And I know, Brian, your team also has been working on good guidance practices and other issues. So I'd welcome your thoughts on that and what Congress can do to prepare for the next round of user fee negotiations.
Yeah, so on Chevron, it's a big deal. There's no doubt about it. You have agencies that would try to find ways how to stretch the laws and stretch their authorities beyond what Congress ever envisioned them to have. And I think Chevron hopefully will limit that, and if agencies self-regulate, hopefully it won't lead to a lot of litigation. That being said, I've heard these sort of really just out of control sort of scenarios on what's going to happen because of Chevron. I think someone said that you can now sue the agency because of their decision to approve a drug or not approve a drug because of Chevron. There has been litigation on FDA approvals beforehand, but before Chevron. But Chevron's not going to change that because it was pretty clear under the decision that questions of law, yes, would be for the courts, but questions of fact, questions of scientific expertise would remain with the agency. Congress has clearly delegated the authority to FDA to make decisions on safety and efficacy of drugs. That's not going to change. So the sky is falling, no agency will be able to do anything, I think is a little overwrought. As it relates to the user fees, this really actually gets me exciting because I'd say probably the two things that I worked on the Hill that I look back the most fondly were the 2007 user fee and the 2012 user fee bill that I worked on when I was at Energy and Commerce. The user fee programs fund medical device review, generic drug review, human drug review, and they have to be re-upped every 5 years. The industry negotiates with the agency on what that amount should be, and then they agree on goals that the agency will meet for that amount of money. Now, one thing, it does not guarantee that you get approved of a drug. It just guarantees that you're going to have you're going to actually have a predictable decision time frame, not a yes or a no. But yet, what usually happens is it's our every 5-year opportunity for Congress to actually examine the FDA. The user fees expire in 2027, so next Congress is really going to be the teeing up of those issues that will be attached to it. So every user fee cycle, there tends to be a theme where we have a lot of extraneous material that's attached to it. In 2002, it was right after the anthrax attack, so that's where we did all the biosecurity legislation. In 2007, Democrats were in control. They really wanted to beef up drug safety at the agency. In 2012, we did a lot on innovation and how we can ensure that the U.S. sort of remains the preeminent market for the introduction of new medical products. 2017 was a little bit weird because it came right on the heels of the passage of the 21st Century Cures Act, which actually did do a lot of FDA-related policy decisions. So that was a lot of cleanup of cures. What I think is going to happen next year as they go in and start fleshing out these issues is really how do we modernize the FDA so they have the expertise and the tools to take advantage of some of the cutting-edge technologies that we know are coming, right? I think it was 20 or 20, well, it was 22, Senator Burr at the time got a provision in the user fee bill related to platform technologies. That could be really transformational in terms of allowing a whole panoply of new therapies to come to market, but also condensing the time and condensing the cost of developing new products. You mentioned AI is another one. We are also on the cusp of what's known as personalized medicine, where you can make one drug for one individual, but we really don't have a regulatory structure that's ready to approve those products in a timely way. So that's what I think is going to be sort of the crux of the 2027 user fee cycle, but you're going to see a lot of those debates really materialize next Congress.
So people have been texting me questions, actually, as I've been sitting here. So I hope you don't mind if I victimize some of you guys with them. One of the questions, and one of the things, and I've heard about this a lot, reading in journals everywhere. What are we going to do about primary care, right? How do we strengthen primary care? What can be done to make primary care accessible? It's hard to get a primary care appointment. You often have to wait a long time to get a primary care appointment or even access your existing doctor. So what do you think can be done to expand the accessibility and quality of primary care? Very easy question, one that we've been able to solve together over the past 20 years.
Sounds like you'd be the best person to answer that as a physician yourself.
Oh no, I'm going to defer. This is the privilege of being the moderator.
I would just start off by saying, look, I think we have to rethink how we deliver healthcare in the country. And as Brian said earlier, I think we need to give freedom to people to utilize their dollars to make the decisions that best fit their need. And I think that then creates an incentive for people to go into the practice of primary care because there'll be more demand for it and actually paying customers who want to engage in it. I would also say our colleagues at Heritage on the education side have done a lot at looking at what do we need to do in the education system of medical schools itself so that we have enough backfill there to fill in where we need additional people here.
And I, as a former bureaucrat and current physician, I can say I'm excellent at doing paperwork, but I don't think that we want paperwork to be the primary driver of how physicians spend their time. I know, Brian, that Paragon came out with a paper today on AI and talking about the automation of administrative tasks, which is something that my team has also worked on. So I would add that facilitating standards development organizations to make prior authorization less painful, integrating that into the electronic health record. And we have legislation actually in Congress right now being considered related to prior authorization.
Yeah,
So
I mean, this is another Medicare problem too, right? Medicare and the way that they determine physician payment, it tends to be dominated by specialists. I think historically underpays primary care services relative to the specialists that dominate that RUC process.
Right, and a physician fee schedule fix might be able to address that, yes? So another question I got, which is very direct, this is fun. Will there be any electoral or other political accountability for bad COVID policy?
If Rand Paul is the chair of the Senate Health Committee.
I would like to give credit to both the House Select Committee, Energy and Commerce Oversight, even the Senate, I think recently had some hearings, or they're going to have hearings. There's a lot going on. I think the noise factor is hard to kind of get attention to it. It doesn't have perhaps as much sizzle as some other things that are happening in the news today. But I give them a lot of credit. They are uncovering and creating a very good picture of what actually has happened and really holding people's feet to the fire. That will then create an opportunity for Congress and an administration, regardless of what the administration is, to hold people accountable because that's their obligation.
I think one of the biggest or stories that haven't necessarily been talked about is there were a lot of people that had other ideas on how to approach the pandemic. 2020 was a chaotic time. People didn't, especially February, March, April. By May, June, we really did have a lot more information about the disease and what we needed to do. I think we knew we needed to have kids back in schools, that it was safe for kids to go back in schools. Europe was doing that. But in the US, if you said that, you potentially got deplatformed. Or fired. And I do think that we need to look at, the sort of the First Amendment issues and the ability to have scientific discussions in an open way, especially when we come to find out that what we were told was science was not based on really any data or evidence at all.
So we're going to open up to questions. So obviously raise your hand if you're online, submit your questions. They will get texted to me as they have been coming in quite robustly during this time. I have a good question here on 340B, Ryan. Says, even though for-profit hospitals provide as much charity care as nonprofits, I actually think they, in some research suggests that they provide more actually charity care. For-profit hospitals are not eligible for 340B and other programs, do you think the next Congress would be interested in providing parity between for-profit and nonprofit hospitals, right? I think probably more accurately, tax-paying and tax-exempt hospitals.
I don't think that that's really come up, but there has been questions, particularly by the Ways and Means Committee and Senate Finance Committee, of the not-for-profit status of some of these hospitals and whether they're actually meeting the sort of the goals and what they are supposed to be doing in terms of providing charity care. As you said, there are for-profit hospitals that provide, in some cases, exponentially more charity care than not-for-profit hospitals. I don't see us expanding the 340B program, but I do think that within the confines of those hospitals, and again, there are different eligibility criteria for 340B hospitals, that we have more transparency on how much revenue they're generating from the program and where that revenue is being spent and whether patients are actually benefiting from the discounted drugs.
Follow-up question, what about expansion to for-profit hospitals in a budget-neutral fashion?
Well, you know, that's one of the things that the pushback is, why do you have to do anything on 340B reform? It's a federal sort of structured program, but it doesn't really have any federal budgetary impact. And I guess directly that's true, but indirectly it's not, as Brian said. And if the 340B program is designed to incentivize consolidation, because if you're a hospital, you can go buy a physician practice and you can buy, 8 physician practices around town. We saw a really good article, I guess, from 3 years ago from New York Times related to a hospital in Richmond. It's an inner city hospital, and they were buying all these physician practices in heavily commercially insured areas. That does actually have an impact on the federal budget because it drives up overall healthcare system costs, which the federal government pays for well over 50% of.
I'll just, CMS does a very bad job of ensuring things are budget neutral as well. So it sounds good in theory, but in practice, it would not work out.
But there's not a budget neutrality test for 340B.
Yeah.
And so another question that I received was, what about the Medicare Advantage Star Ratings program? Is that seen as a subsidy to health plans? And if so, how would it be improved?
So we recommend scrapping the quality bonus payment program. As in MA, we don't think that it correlates very well with the quality of the plan. And there's things like double bonus counties that don't make a lot of sense. So the elimination of bonus payments is one of our main recommendations for MA reform. Not that we would get rid of star ratings. We think that you'd have star ratings and they'd be available for consumers to be able to compare across plans. But as far as linking the payments to the MA plan, we don't think it is particularly good payment structure.
And I do believe consumers are, sort of walking with their feet, right? Because 80% of beneficiaries in MA are in a 4-star or 5-star plan. They don't know that they're getting a bonus payment, but they're going to where the plans are that have the highest stars.
And it also seems like anytime the government tries to build something to reward something, there's gaming that comes out of it. And so how do you make sure that you have the right guardrails in there? Otherwise, we're layering more problems on top of an underlying problem.
But I think regardless, to Brian's point, we have to make sure that what we are measuring actually has a benefit to patients in the system.
Yeah.
Well, open for other questions. I've been getting a few here, but we also welcome questions from our live audience. So another question that I got texted is, what would you do on day one of a new congressional session? What would be each of your number one priorities?
Well, I have 3 words: transparency, accountability, and oversight. We've got to start exposing what's going on before we try to start fixing things. I think one of the lessons of reconciliation is make sure we have everything lined up, ready to go. And the best way to do that is to have very aggressive transparency on how the government programs are operating, greater accountability of those that are participating in those, whether it's the states or providers, and then really having a really robust oversight of how these programs are being run.
Another question is,
Can I just say, I think I agree with Nina's answer. I think there's a lot of education that has to go on. I mean, I do really think our primary pressing issue that we have to face is the increasing deficits, the debt, the interest payments. I mean, we're spending more on interest now than we are on national defense and Medicare, and the inflation that comes out of that. And I think policymakers really need to understand what's contributing to the state of the federal budget and our deficits. And health entitlement programs are the driver. And if we don't get control over federal health care programs, the budget is going to continue to grow out of whack, and interest payments are going to continue to rise. And there's just a lot of education that's needed for policymakers as well as the general public on the extent of that problem.
I do think the American people have felt the effects of overspending.
Yeah.
It is the $2 trillion bill that they passed in March of 21 that lit inflation on fire. And that had real world impact to people, because now you want to go buy a house and you're buying a house at 7% interest rates. You want to go to the grocery store and things cost 20% more. But it also has a major impact on sort of federal policy making, the federal budget. We now spend over $1 trillion a year just on financing our debt, not even paying it down, financing it. That's unsustainable.
So I got 4. Is there a question? Yes, go ahead.
Yeah, first of all, thank y'all so much for being here. Yeah, thank y'all so much for being here. This was very enlightening. I wanted to ask you, Mr. Blaise, going back to the subsidies that you were talking about, I guess one of the questions I had, because we've been talking a lot about it as well, is let's say another administration does come in, right, and we're looking at these subsidies specifically. In the case that Obamacare as a whole isn't really going anywhere at the moment, do you believe that these subsidies have any value? And if so, is there a way to keep them? Is there a way to fix this fraud? Or could you give some more background on that?
Sure. So I agree that core aspects of Obamacare are not going anywhere. I think I'm separating out the original premium tax credits in the law that passed in 2010 and that took effect in 2014 with the enhancement of those subsidies that President Biden signed. I would recommend that those enhancements, they expire after 2025 for the reasons I outlined. I mean, the waste and fraud is just part of it. They give incentives for employers not to offer coverage. Extending them is incredibly costly. And they're inflationary, right? You are bringing more people into a structure where the taxpayer bears the full burden of the premiums going up. I think there's ways to deal with Obamacare that will help people that have been harmed, but that leave the general infrastructure of Obamacare alone. So I think what the Trump administration did, opening up options outside of Obamacare for the people that are harmed by that structure, making it easier for small businesses to offer coverage. So we did, the Department of Labor did a rule that allowed small businesses to join together to offer coverage and get some of the economies of scale and regulatory advantages that large employers get. It was actually off to a good start. There was a district court judge that said it was an invalid expansion of ERISA, struck it down, and there was an appeal, but the Biden administration halted that appeal and then rescinded the rule. Right? It's really, I mean, Republicans should argue to help small businesses offer coverage. There shouldn't be advantages that large businesses have over small businesses. So I think options outside, and I'll mention one other policy recommendation. So much of the federal government is going to subsidize health care for low-income people. What is a better way to do it rather than send all the subsidies to the health insurance company? So what we have done is develop an option for enrollees that they can take a portion of the subsidy under their control. So instead of this subsidy going to the insurance company for the insurance company to reduce plan deductibles and out-of-pocket limits, the enrollee would get an actuarial equivalent amount in a health savings health savings account or health savings like account, and then they would actually control it. So what can we do on the margin to remove all of these, to move a portion of these subsidies away from the insurers and the healthcare providers to the actual consumer?
I want to add one more point, just to add to what Brian said on the enhanced subsidies. Let's not forget, those came into effect because of COVID.
Yeah.
So as I said, we found some way to wind down the Medicaid COVID spending, but we're not winding down these COVID ACA subsidies. That should be a no-brainer.
So there's another question. I just got texted 4 or 5 questions. This one I think is probably for Ryan and I. It says, are there any new ideas out there for reducing the burden of the opiate epidemic? For example, reducing burdensome regulation around medication-assisted treatment clinics, or maybe increasing the regulations if people think that they need more.
I mean, going back when I was with the speaker, we had a lot of discussions with members, prior to becoming the majority. He created the Healthy Future Task Force, and we talked to almost every group within our conference. And this issue was probably a top 3 issue for every single member. It affects every single community. And there's no one silver bullet. I think there are a couple of things that we need to do right off the bat. One is there's what's known as the Support Act reauthorization that would reauthorize a lot of programs that were first passed in 2018. I think everyone is hopeful that can get done in the lame duck. That does a lot in terms of treatment and medication-assisted therapy. I think the second thing is we have had a lot of difficulty permanently scheduling fentanyl. Because fentanyl in and of itself it is a medically approved product. But when we talk about fentanyl in terms of street fentanyl, it's usually they change one little part of the molecule, and it makes it so it's not illegal. And that's really challenging for law enforcement because you can't do the things that you would normally do in terms of arresting or prosecuting people. Now, the Republican House has passed permanent scheduling of fentanyl. It unfortunately hasn't gone anywhere. And really the big hiccup was the Biden administration's insistence that if we permanently schedule fentanyl, then we have to exempt fentanyl traffickers from mandatory minimum sentences. I think the other thing is we got to do something on the supply side. The demand side, yes, we have to do. We're going to do it with Support Act, and I think it's something that the Trump administration, he actually created a public health emergency related to opioid addiction to provide more resources to communities. But on the supply side, we know where the fentanyl is coming from, and we have to do something that's not necessarily a healthcare issue, that's more of a border issue, but it does go hand in hand.
I would say on the treatment end, yes, those regulations around those products need to be addressed, the specifics of which are probably too lengthy to discuss a panel up here. But part of that also is integrating behavioral health treatment into primary care, which is something that we have all talked about for years, but operationally has not actually happened for the patient. So if you have opioid use disorder, you should be able to get treatment at any routine primary care clinic. And right now, today, you cannot do that. So many folks who suffer from opioid use disorder end up accessing a completely separate delivery system for a lot of their routine care, and we need to reintegrate that. Another question is, can we hear the panelists' views on upcoming health data privacy legislation at the state level? For example, My Health Data of Washington, and what are the chances of seeing a federal health privacy law similar to that or other legislation?
I'm going to claim ignorance over the Washington state law, so I'm going to have to do a little more research on that.
I think in general, just a general comment on the data is ideally you want the people to own their own information. Mm-hmm. And the more we can move towards that, where you're controlling who has access to your data, the better off we'll be, as a general principle.
And then another question was, during COVID, the Trump administration used a creative solution to get real-time data on hospital and ICU availability by tying payments to hospitals to timely reporting data. And do you think that there's any congressional interest in this kind of incentive again to get better real-time data monitoring for public health purposes instead of relying on CDC reporting that is many weeks delayed?
I mean, you do have to balance questions of burden and cost to what the benefit that you're going to get. I mean, COVID in 2020 was a very unique situation. And we did have real problems with CDC reporting and the reporting lag. Do I think that doing that on a sort of a permanent basis going forward with a whole host of different conditions, I don't know the cost benefit of that. Do we need to improve CDC reporting? Like, that's without question.
Other questions from the audience? Yes.
This one's for Mr. Long. One health policy wonk who shall go nameless has pointed out that for site neutrality, there may be an issue where instead of dropping hospital prices down to where physicians are at, we would just, as a political compromise, raise physician prices up where hospitals are at, which kind of gets rid of the budget saver argument for the policy. Do you think that's a possibility in Congress?
I haven't heard that.
I would say a follow-up question to that is, do you think that with site neutrality, there's a potential to split the difference as opposed to completely increase one or completely decrease the other?
I mean, yeah, that's a interesting intellectual discussion to have. I think at the end of the day, to Brian's point, we do have to make sure that we don't have disincentives or incentives that actually increase healthcare system costs. And we need to look at what the federal programs are that actually lead to consolidation. Now, is that, a split the difference, a potential compromise? I mean, legislation is always a compromise. But I think the biggest thing is making sure that we deliver the most efficient care in a way that is responsible for taxpayers and provides quality care to patients.
Let me say one of the nice things about site neutral payments in Medicare is there is like bipartisan agreement that we should move towards in this policy direction. So former secretaries Azar and Sebelius, obviously different political parties, had a joint op-ed in Stat News arguing for that. Paragon is co-hosting an event with AEI, Ben Ippolito, CAP, and Brookings, where we have agreed of the importance of site-neutral payments and want to show sort of policy support across our different organizations that certainly view things, many issues differently, but that there is sort of a very common sense rationale to do site-neutral payments. And it really is the hospitals that are the ones who, for self-interest, clearly don't want to do this, but that the policy experts largely agree that this is a good policy move.
It's a very, very bipartisan group. I think that almost never happens in healthcare policy.
Yeah.
Well, one final question.
So I'm wondering if any of you think that government assistance in healthcare through things like Medicare and Medicaid increases the overall healthcare costs?
Dramatically.
Thank you. Yeah.
Yes.
Well, thank you all for joining us today at the American Enterprise Institute, and a round of applause for all of our panelists.